There are two things that I want to do before we start formally. The first one is a little formal statement by myself. Now, I realise that some of you attending or watching yesterday may have expected to see or hear more in the way of acknowledgement of the impact the pandemic had on individuals and families. The reason that didn't happen is that this presentation was not designed as a formal hearing of the inquiry, but as a session on epidemiology, on science. The focus of this session is to help those interested in the work of the inquiry understand more about the underlying science, which will form the basis of much of our investigation and, of course, deliberation throughout the coming, no doubt, many months. On the 28th and 29th of August, as I told you yesterday, we will have a further hearing, or we will have a hearing, and the focus will then shift from the science to the people affected by the virus and the strategic response to the virus. On those days, we will hold what we consider to be our official preliminary hearing, and that will constitute a formal opening to the inquiry's evidence gathering and hearings to follow, which I think, again, as you all know, will commence late in October. At that stage, in August, there will be an opportunity for core participants to the inquiry, including, of course, bereaved families, care home relatives, and others affected, to participate. We also plan to show a film at that hearing to highlight the impact of COVID on people, to signal the beginning of our hearings dealing with impacts on the people of Scotland. I should say that I'm grateful to those families and individuals who provided photographs which we've used in that film, and I thank them for their contribution and their ongoing participation in the inquiry. They are and will continue to be at the forefront of my mind when conducting the work of the inquiry and when it comes to deliberating and considering the report. As I said yesterday, core participants will receive a communication from the inquiry next week, providing more and detailed information about what to expect from the August hearings and how they should participate therein. So I hope that clarifies matters. That's the first thing I wanted to say. The second thing is that Dr Croft has kindly told me that he's realised on consideration last night, he made an error of a technical nature, and he'd like to correct that, and I think that's entirely appropriate. And can I simply ask you to explain what the error was and then correct it?
Yes, thank you, my Lord. If I could ask you, my Lord, to turn to page 463.
463.
In fact, before that, let's turn to, come back to 463, let's turn to page 659. This is about gargling to prevent COVID-19.
Yep.
Which we just using it as an example of Cochrane reviews.
I remember that. 659, did you say?
659. And
yep.
So.
Yes.
Yeah. So.
The Almanza Reyes and Gutierrez Gargling papers.
Right.
Yep.
So we started yesterday. We began by talking about Mr. Gale's hypothetical acne, and Mr. Gale went to his GP and he said, right, doctor, what's the risk of my being cured of my acne, my hypothetical acne, if I take this antibiotic? And the doctor said, the risk is, in other words, the likelihood of you being cured is 60%, because in the trial, of those who took the antibiotic, 6 got better and 4 didn't get better. So 60% likelihood. What's the risk of your getting better if you don't take the antibiotic? And if you remember, the risk was 30%. So therefore, the risk ratio was 2, meaning he was 2 times more likely to. Yeah. Right. So applying that same understanding to the gargling, if you remember, Almanza Reyes and Gutierrez Garcia were 2 randomized controlled trials, both in Mexico, and they both involved healthcare workers. Mm-hmm. And they were quite small numbers, but produced a very powerful effect from gargling. And the combined impact of the combined pooled effect measure gave a risk ratio of 0.07. Mm-hmm. Could you see it on the third line down? With a confidence interval of 0.02 to 0.23.
Yep.
And in the heat of the moment, I said that means that 93% less likely to get COVID-19 if they were gargling than if they weren't, and that's incorrect. These were healthcare workers working in Mexico in intense environments where the transmission of COVID-19 was very intense, so they were obviously quite alarmed and worried. And they did this gargling. The first group were gargling with a solution of silver nanoparticles, and that was compared with a group who just did conventional gargling, we don't know what with. And the second group, Gutierrez Garcia, they were all wearing PPE. It's interesting. Both arms of the trial, and the experimental arm were also gargling with this neutral electrolyzed water, and they did that 3 times a day, and the other group did it for 3 times a day. The first group were followed for 9 weeks, I think. Yeah, they followed for 9, and the second group were followed for 2 weeks. So they weren't very long trials, and this again the pooled effect measure was 0.07. So what does that mean? It actually, what is the risk ratio? It's actually 14. So it's 100 divided by 7.
Okay.
So in other words, the people who were gargling were 14 times less likely to acquire COVID-19 than the doctors and nurses who weren't gargling, which is impressive. And you don't often get such good effect measures, but this is, I think, indisputable because they were randomized controlled trials, they were well done, and the heterogeneity was 0. The I-squared was 0%, so it was reasonable to combine these 2 trials. And the confidence interval there is, you can see that along that dark bold line, ranged from 0.02 to 0.23, so therefore we can be confident, we can have 95% confidence that the true measure lays somewhere between 50 times more protected, which is 0.02. They might have been 50 times less likely to acquire COVID, or it might have been 4 times less likely to acquire COVID, which is 0.23. So that I think is a correct interpretation. Okay. It might have been helpful if Jefferson had given some interpretation. They just put this forest plot in because they obviously found it interesting, but they were so busy talking about other things they didn't interpret it. So that just to finish, my lord, tells us a couple of things. Firstly, there are very effective measures that one can apply to prevent COVID-19, such as this one: simple, effective, cheap. You had also in the Gutierrez Garcia, you see the control group were wearing full PPE, but nevertheless they still had quite a high number of cases of COVID, 10 out of 79. So it shows there may be some protective effect, but the ones who were wearing full PPE and also gargling only had 1 case out of 84, so much better to be gargling. And it shows you can do randomized controlled trials even at times of high COVID intensity amongst, you could, as long as they're designed correctly. They don't have to be expensive. The second group said they had no funding. The doctors and nurses just decided to do it amongst themselves. And so this preempts a possible argument that might be used by the policymakers. Well, we couldn't do research at this time because everything was so fraught. But people were doing good trials. We may later on discuss the Danish trial and the Bangladesh trials that were done in this time. So my last point, sorry to go on, my last point is what made these doctors and nurses in Mexico do this? Which seems odd. Yeah. And the answer must be they must have read the science. They must have read Jefferson 1, which is the precursor of this, and that was the original systematic review that came out in 2011. Yep.
2011, yeah.
And if we look at Jefferson 1, again, there's a surprising page 463. That's the third forest plot down, called Analysis 1.9, Case Control Studies, Outcome 9, Nose Wash. And they must have looked at that and thought, that's pretty impressive. So they're looking at 2 studies there, Chinese studies, that were done in China during SARS outbreaks, mini outbreaks.
Yeah.
And these are case control studies, so they're not as powerful as randomized control trials. case-controlled studies are what they call quasi-experimental studies, and they're level 2B evidence in that hierarchy. But essentially what happened here was that Chen and Liu, Chinese investigators, they compared cases, people who'd got SARS and then they recovered, and then they matched them against, they're all healthcare workers, we think, and they matched them with equivalent age-matched and sex-matched healthcare workers who didn't get SARS, and they worked out, well, what was it that enabled one lot not to get SARS and the first lot not to get SARS, and they found a powerful protective effect from nasal gargling or nasal washing of some sort. And so, and interestingly, the diamond there shows an odds ratio which is similar to the risk ratio, which is 0.3. So it's same kind of order of magnitude as the Mexicans found later on. So that I think explains all of that, and it's of interest, and I think of practical importance as well.
Yeah.
Thank you, Madam.
No, thank you very much indeed. Yes, now, Mr. Gill, when you're ready.
Thank you very much, Mr. Lamont. Doctor, we had reached at the conclusion yesterday afternoon, page 11 of your report, and section 2.3 headed "What are coronaviruses?" I want to take quite a lot of this short because it's there for everybody to read.
Yes.
Those who wish to investigate it further will have the opportunity to do so. I think you indicate towards the bottom of page 11, the last paragraph, that the coronaviruses are further categorized according to a classification scheme developed by in the 1970s by the Nobel laureate David Baltimore.
Yes.
And then there are 4 features: the molecular architecture, their genome, their replication strategy, and whether in the case of RNA viruses they are positive or negative.
Yes.
Now, I'm slightly interested in what is said in the second paragraph on page 12, where it is said that RNA viruses, which I think we know as COVID was one of those viruses, have high error rates, with genomes diverging by as much as 2% in the course of the year. That's 1 million times greater than the divergence rate of eukaryotic cell genomes. Now, can you translate that for me, please?
Yes. Thank you, Mr. Gill. That's a direct, word-for-word, a transcription from a textbook. Yep. And it's in jargon for which I apologize. So I've lost the place on the page. We're on page 12.
We're on page 12 of your report,
okay.
the second full paragraph on page 12.
So
RNA viruses, it begins.
Right. So RNA viruses are single-stranded nucleic acids, and so they don't have that same, shall we say, property of DNA viruses that are double-stranded, and DNA viruses, as they replicate, are less likely to have slight changes in their molecular structure. So that's my understanding of this concept. So because they're more fragile, every time they replicate, and that's their whole purpose in existence, which is to replicate, every time they replicate, there may be slight changes in the molecular structure, particularly in the ordering of the nitrogenous bases we were talking about yesterday, the guanine, adenine, cytosine, and uracil in the case of. So if there's a slight ordering in those bases, the code for which they exist is different. A bit like a computer code. It's similar to a kind of virus that gets into your computer and makes it behave slightly differently. So the error rates, so the genome is the totality of their genetic information, the total genetic profile, and that can change with viruses, as I said here, about by 2%. So in the course of 1 year of continuous replication, you may end up with viruses at the end of it that are 2% different to the original parent virus. That's how I understand this. And quite what that means is hard for us to understand. But the reference I've taken that from goes on to say that this is 1 million times greater than the genetic transformations that would be seen in eukaryotic cell genomes. Eukaryotic cells are those that are found in advanced organisms such as humans and mammals, and so therefore our genomes are also undergoing slight mutations all the time, or slight changes, but nothing like the rate that we see in viruses.
You go on in that paragraph to say many of these viral mutations
Yes.
are non-functional.
Yes.
And then you qualify that, but some will allow the virus to evade host immune responses and medical therapies.
Yes.
Is this effectively a mutation?
Yes, that is a mutation. Yes, every change in the genetic structure will be a mutation, but in general, mutations, and we undergo mutations in our cells, particularly those, for example, on the skin that are exposed to ultraviolet light, they may mutate. And some of those mutations in our cells may cause the cells to become cancerous, to lose their normal properties. But so most mutations don't result in a functional advantage for the cell or the organism, but some of them might. Some of them might make the virus more pathogenic, more easily transmissible, and therefore, if they're more easily transmissible, they may get into cells more easily. They may evade the immune response more readily, and therefore they become more pathogenic.
But perhaps to put simply, they become a moving target so far
correct.
as human immune responses and medical therapies are concerned.
Of course, we see the same phenomenon with influenza viruses,
Yes.
which are, again, RNA viruses. They're around us all the time. And when conditions are particularly good for their transmission, which means the winter, they will cause disease. And all the time influenza viruses are undergoing slight mutations. It's called antigenic drift, so there's a tendency for them to be always a bit different. Occasionally influenza viruses will undergo a major mutation, and that is termed antigenic shift, and that gives rise to a new subtype of influenza virus, which often can be very dangerous because the new subtype may be one that people have never been exposed to because it's so different. And the same phenomenon, as I understand it, I'm an epidemiologist, not a virologist, same phenomenon is seen in coronaviruses, where they're, as you say, Mr. Gale, they are a moving target.
Could you just read the final paragraph so we have it in the notes? It begins in summary.
Yes. In summary, coronaviruses are enveloped, single-stranded, positive sense ribonucleic acid viruses that infect mammals and birds, and that typically, but not exclusively, target the respiratory tract of their hosts.
We move on now to what diseases are caused by coronaviruses. I think some of this we've already looked at in the context of your appendices on SARS and MERS.
Yeah.
I think we can take that as read. And I think yesterday you indicated that there were 7 known human coronaviruses, and that's set out in the table on page 13. And I think the first 4 of those coronaviruses are the ones that you didn't specifically refer to, but I think they're there just simply for the record. And the ones that with which you were concerned are the last 3, MERS, SARS, and SARS-CoV-2.
Yes, those are the novel coronaviruses that emerged, we don't know with certainty how, but more likely than not as a result of some kind of animal reservoir spilling over into humans.
Yes. Can we move over now to 2.5, page 14, and there we'll see, again, this is some material that we've already looked at, as you say, the term is architecture,
Yes.
and that is shown in the figure. Again, I think one of the things that probably most of us do remember from general presentations during the COVID pandemic was the significance of the spike, hence the name corona.
Yes.
Can you just explain what the spike is and what it does?
Yes, the spike of SARS-CoV-2, this picture shows SARS-CoV-2, which is very similar to the original SARS virus, coronavirus that caused SARS. And first of all, it's quite a large virus, so it's quite complex. So potentially, there's the possibility of it changing in unexpected directions and causing problems with an immune response. But it's surrounded by these spike proteins which project from the envelope. The spike proteins are the means by which the surface protein by which the virus achieves entry into the target cells of the host, which may be an animal or may be human. And how the virus does this is through identifying and fusing with a receptor, which is a protein on the surface of the cell called the ACE2 protein. Yes. So the spike protein attaches to that receptor, undergoes a slight transformation, and then the virus can then enter the cell through that entrance. So I consider it's a little bit like a Yale key, which will fit into a lock. It won't fit into other locks, even though there are other locks, and it'll open the lock, and then you can go in. Just to go back to the previous table, the receptor that SARS-2 has, so the table on previous page, page 13, that's the table of the 7 human coronaviruses. Yes. That's one. So if you look at the right-hand column, my lord, you can see that SARS-CoV-1, which was discovered in 2003 and caused the epidemic of SARS, has the same receptor, the ACE2 receptor, angiotensin converting enzyme 2 receptor as the SARS that we're preoccupied with now. And that was quite helpful because a lot of research had been done on the ACE2 receptor and exactly how SARS-CoV-1 interacted with that. So quite a lot was already understood about the dynamics of infection with regard to this novel coronavirus.
I think we can also see in that table that the virus identified in 2004 had the same entry receptor.
Yes, that's right. Yeah.
Yes. Right. Can we go back to page 15, please?
Yes.
And I'm interested, again, just taking various passages from what you say. I'm interested what you say in the second paragraph on page 15. What you say there is the mutations that SARS-CoV-2 accumulates facilitate the phenomena of immune escape, meaning that reinfection with the virus can occur after natural infection and also after vaccinations.
Yes.
So is that essentially saying that we can expect to be infected with COVID more than once, even if we are vaccinated?
Yes, just as we can expect to get flu more than once. Yes. But there may be some degree of, continue with flu, with every flu season there'll be a slightly different flu variant, flu virus variant. In fact, there are a number of influenza virus variants circulating all the time. It'll be slightly different to last year's because the virus is mutating all the time.
Yes.
But often we will have a degree of cross-protection from at the time that we last encountered that flu virus. So it won't affect us badly. And the same we would expect to find with SARS-CoV, that if we've acquired it, especially if we've acquired it naturally, we may well acquire it again after a period of perhaps a year, but we are likely to not have such significant illness the second time round.
And I think that's what you say in the following paragraph.
That's of course, here I'm quoting the indisputable scientific literature. That's my reading of what I set out as indisputable facts.
We move on to 2.6, we're now looking at the spread of the virus, and you concentrate first of all on airborne spread versus droplet spread of respiratory pathogens, and the distinction that you then set out in the following paragraph. And I think you say that the distinction is based on the size of the infecting particle, particles rather. And
yes.
The airborne spread, very small particles, and you've given their dimensions. And then you move on to droplet spread. In very simple terms, what's the difference between airborne spread and droplet spread?
Well, I'm not convinced there is a great difference, but enormous arguments rage about the difference and what it means. But basically, they're transmitted through the air. But some particles are heavy, I guess, surrounded by mucus, and they fall on the ground around you, and others are very small and light, and they waft through the air for some distance. I guess in practical terms, if most of the transmission is occurring through the droplets that are falling around you, then you want to focus on the immediate environment. Whereas if most is occurring at a distance, the immediate environment might not be as important. But with most respiratory virus, it does seem to be the case that it's a combination of the two, the airborne and the droplet spread, that results in transmission.
And I think in relation to airborne spread, you do say that being very small, the infective particles can remain suspended in the air for long periods of time,
Yes.
and travel long distances and be inhaled into the air passages of potential new hosts.
Yes.
Droplets, as you say, I think, put it crudely, tend to be perhaps more localized. You make reference in your discussion on droplet spread to droplets contaminating environmental surfaces or inanimate objects, that is fomites. Now, I think you do define it. We don't need to look at it, but you do define what fomite means. And I think, again, we've probably all heard of, during the pandemic, of the need to wash surfaces and handrails and etc. Is that what you're talking about?
Yes, and that would seem to be quite a logical thing to do, and one that doesn't involve a great deal of inconvenience or expense.
Yes.
But it's all part and parcel of basic hygiene.
Yes. And the problem, obviously, is that if somebody touches somewhere where there is an infected droplet, and then puts their hand to their mouth,
yes, indeed,
that is a potential transmission.
Indeed, and your mask might become a fomite if either you have put infectious droplets onto it by breathing out, or you've breathed in infectious droplets. It potentially could be a fomite. So masks have to be worn correctly and disposed of correctly.
Yeah. And I think then in page 16 going on, you helpfully set out the range of infective particles, size, and hence their predominant mode of spread will be affected by factors such as, and you list them, the volume, the character of the secretions, the extent to which droplets are converted to aerosol particles by evaporation. That's perhaps something perhaps you might explain. How does a droplet become? How is a droplet evaporated and converted into an aerosol particle?
Well, if droplets are mainly fluid and they're landing on a surface, especially if they're exposed to the sun, they will evaporate in the way the
Simple as
fluids
that.
do. They end up as minute airborne particles.
And then you refer to the duration of airborne suspension,
Yes.
which is influenced by environmental factors, and we'll come on to those environmental factors
Yes.
in a minute. But that includes temperature, humidity, and prevailing air currents.
Yes.
And then finally the distance travelled, which again is obviously influenced by environmental factors.
Yes.
If you just read from the bottom of page 16 to the end of that section, Doctor, so we just have effectively your summary.
Thank you. So really this is the summary of the, I think, undisputed knowledge about transmission. In reality, both the size of respiratory particles produced by an infected person and the distance they can travel are likely to fall within a spectrum for any given respiratory pathogen. Therefore, disease acquisition may occur through both the airborne and the droplet mechanisms of spread.
And obviously, the same transmission can be occurring at the same time.
Indeed, yes.
You then go on to talk about what you say are the aerodynamic factors. And I think you begin by prefacing this with the word perplexingly.
Yes.
And you say, and although COVID-19 is generally thought of as an acute respiratory illness, there are very low levels of SARS-CoV in the respiratory tract during the early phase of disease.
Yes.
This is the case of all coronavirus infections. Is there an explanation for that?
Well, it does seem to be the case that the virus particles are particularly trapped in the nasopharynx, which is the next paragraph, and they don't go straight into the lungs, which is the mode of transmission with some airborne diseases, for example, TB or asbestosis. You have to have a particle that wafts straight into the lungs and causes the problem there. So the nasopharynx is acting, it would seem, as a kind of a filter and first line of defense by collecting all these virus particles, and then from there they disseminate to the rest of the body. And that ties in with what we were just talking about, which is nasal washing and nasopharyngeal gargling.
If we go on that page to the penultimate paragraph, SARS-CoV-2 is primarily transmitted from person to person, following close, and that's less than 6 feet, 2 meters, exposure to respiratory fluids carrying infectious viruses. And then you give examples, very simple examples of somebody breathing, singing, talking, coughing, or sneezing that release large infective particles, droplet nuclei, into the air. And these particles may add to the exposed mucous membrane, may land, on the exposed mucous membranes of a host, causing infection. Okay. And then you go on to infection from touching contaminated surfaces, which you say is also possible. And then perhaps you just read what you say at the in the final paragraph of this section of page 18, at the top of page 18.
So the paragraph starting finally.
Finally.
So finally, SARS-CoV-2 exposure can occur when very small infective particles, and as a reminder, these are called aerosol particles, suspended in the air are inhaled directly. Aerosol generating procedures commonly take place in hospitals and in dental surgeries. Hospital procedures in this category include, but are not limited to, tracheal intubation, manual ventilation, non-invasive ventilation, and the use of certain high-flow oxygen treatments.
Thank you. You then go on to talk about something you've prefaced in the previous section, and the environmental factors. And I think we can read what you say there. I think on a practical level, it's quite interesting what you say that in indoor settings, transmission is thought to be much less common.
I thought I said
I'm
the
sorry,
opposite.
in
It's
outdoor-
opposite, yes, the opposite.
In,
Yes, it's more
in
common.
outdoor settings.
In outdoor
it's-
much less
it's
common, yes.
Much less
Yes,
common.
yes.
Yes.
It is, and it must be, and this would be because the viruses are naturally fragile and they're degraded by ultraviolet light coming from the sun, and fresh air disperses them even more. And it, of course, immediately calls into question what do you do about people outdoors, and certainly in England, well, by way of comparison, in Scotland during the lockdown, the golf courses were open. In England, they were all closed all the time during every lockdown, and to me that doesn't sound logical, because on a golf course you're in the fresh air, you're physically distant from other people, and the risk of transmission must be very low.
I think there was talk in the very early days of the pandemic about the, to use a buzzword, super spreader event, or potential super spreader event of the Cheltenham race meeting, which I think occurred very early in the pandemic. Now, obviously, that was an outdoor, but it was presumably a lot of people in close proximity to each other.
Yes, sure, yes, indeed. Yeah, that foreseeably could have been a super spreader event. Yeah.
Thank you. You make reference at the bottom of page 18 to outbreaks on buses and trains.
Yes.
And you then make reference to what are termed attack rates. And again, I think this is a term you define. But it's the proportion of people exposed who go on to develop infection. And you say that has been as high as 36%. That's in relation to buses. And I think you give the citation for that in your footnote. And then you similarly do that with trains. Then on the top of page 19, you refer to transmission during airline travel. And I think you say it can be as high as 60% in subsections of an aircraft. It probably is fairly obvious as to why that would be.
That section was probably packed, but equally it's interesting that aircraft flights might result in a 0% transmission rate, so it has to be interpreted cautiously, that piece of information.
And I think you then mention Wuhan, and that the experience in Wuhan shows that transmission can be massive in a short space of time, with thousands of new patients diagnosed daily.
Potentially, yes.
Then you have a section on patient-specific factors, and in this section you introduce a qualification on the, I suppose, the degree of infection, and you say that individuals with mild to moderate COVID may shed infectious virus in respiratory secretions for up to 10 days following the onset of symptoms. Just so that we understand, can you put in simple terms what you mean when you qualify the infection as being mild to moderate?
I can't, because it's a subjective term, but what I presume is meant here is generally severe illness is generally categorized as one where the person has to seek medical advice from a GP or from a hospital. So mild to moderate, I imagine, would be the person being at home, not necessarily seeking medical advice and self-medicating, or maybe not even self-medicating, but on the other hand, not entirely well.
And I think you say that that fact was known from early on in the pandemic.
Yes, it was, and it was a factor that was also a feature of SARS. So it was logically a feature also of SARS-CoV-2.
And I think you then go on to say immunocompromised people with severe disease may shed the virus for longer, potentially for up to 10 days.
I think actually that's 20 days. I might have made, I believe
sorry.
that's a transcription error, which I corrected.
Right.
But it basically is longer
Yes.
because they're taking longer to clear the virus.
Yes. So that's the same figures as the one you've given before. So
Right.
it must be different. It must be
Yes,
the
of
20
course.
days. Yes,
I
yes.
beg pardon.
Yeah. And then again, something I think we probably can all remember from the general presentations during the pandemic. You say that the concentrations of SARS-CoV-2 RNA are highest 1 day before symptoms appear, leading to extensive spread of the virus by asymptomatic people not yet showing any signs of illness.
Yes.
Is that effectively one of the dangers of the situation?
It is, yes.
And I think in the next paragraph you do say that some people may remain asymptomatic, albeit having acquired the virus and
Yes.
acquired the infection.
Yes, especially if they're very young and healthy.
Yes. And I think you make the point that in the case of infected children,
Yeah.
at least 1/3 are likely to remain asymptomatic during infection. You then give the example of the Diamond Princess cruise ship, which was quarantined. I think we all remember the footage on the television of this, off the coast of Japan.
Yes.
And what subsequently emerged from the research was that 52% of the 634 people who were laboratory confirmed cases were initially asymptomatic, and most began to show symptoms, but an estimated almost 18% of infected individuals never showed any symptoms of infection.
Indeed, even though one imagines they were middle-aged and elderly passengers, but they were still asymptomatic.
Yes.
Yeah.
Right. Thank you, Doctor. The next section of your report, 210, deals with the origins of COVID-19. Now, this is, I think, an area that probably everybody is now familiar, or at least informed readers will be relatively familiar with. And I'm not going to take you through it in any detail. There are two things I would like to, however, ask you about. At the top of page 21, you say that it is now believed by many that the novel Wuhan virus was transmitted to humans via horseshoe bats and potentially other intermediate hosts to whom individuals may be exposed in wild food markets at the center of Wuhan. And I think that was what was initially thought. You also say an alternative theory is that the virus resulted from a lab leak.
Yeah.
I think there's a lab in Wuhan which may have been seen as being the source of the infection. I take it you're not expressing any view on which you consider. You're just putting those forward
Indeed.
as the two alternatives.
Those are two theories, and I was a bit sceptical about the lab leak theory, but it does seem that the SARS, if you remember SARS 2002 to 2003, there were several subsequent mini outbreaks, and 3 of those, we touched on this yesterday,
Yes.
seem to come from lab leaks of some sort, so clearly it's possible.
Yeah. And I think helpfully, I think we can see the progression over about 20 days of the infection of the persons in the virus, shown in the maps that you've shown on that page, and we can all look at that. The other point that I'd like to take from this section on the history of the virus is what is said at page 22 at the top, where you refer to the basic reproductive rate, which I
Yes.
think we probably all remember being referred to as the R number.
Yes.
I think you indicate that the original wild-type strain of SARS-CoV-2 was estimated as having an R number of 2.8.
Yes.
And as you say, the R number denotes the number of persons directly infected by an infectious case during his or her entire infectious period on entering a totally susceptible population. And then I think you've indicated, by comparison, the R of seasonal influenza is typically between 1 and 2. So, in simple terms, the R number represents the number of people
Yes.
who would be infected by one person.
Yes.
Sorry, having said there are two things, there are in fact three things I'd like to just take from this section. And this further matter follows on from what we've just discussed. If you go to page 25 at paragraph 2.13, you will see you deal with the emergence of variants late 2020. And I think you say there that new variants had emerged carrying several amino acid substitutions.
Yeah.
The variants mostly had higher R numbers than the original wild-type strain and were said to be more transmissible due to mutations in the receptor binding domain of the spike protein. You've explained the significance of the spike protein. And then there are references to two of the variants that I think we're all, again, familiar with. The Delta variant had an estimated R number of 5.1, and the Omicron variant, which emerged in late 2021, had an estimated R number of 9.5.
Yes.
And I think that was perhaps one of the alarming aspects as that information came out.
Yes. Yes.
Yeah.
Yes.
Yes. Can we move on now, Doctor, to 214 at page 26? And you deal at the bottom of that page with how quickly does COVID-19 develop. I think you say that those exposed to an infected person typically develop symptoms between 4 to 5 days post-exposure. Although obviously you've indicated that people can remain asymptomatic during that period. You then say that the median incubation period of COVID, time interval between the individual becoming infected and him or her then developing overt symptoms, is 4 days with an interquartile range of 2 to 7. Incubation period can be as long as 14 days.
Yes.
Now you deal with those who are at high risk for COVID infection. Perhaps I can hand over to you just to read through what you've said there. Okay, so at 214 and following.
215. Who is at high risk for
I'm sorry, 215.
215. Who is at high risk for severe COVID-19 infection? Individuals who are older, male, from deprived areas, or from black, ethnic, or minority groups are at higher risk of severe disease and death from COVID-19. If I could just qualify that, my lord, really the key figure there is older. It's people who are older than 85 years are at very high risk. The others are at increased risk, but those categories are not equivalent in terms of risk, but they are all at higher risk. And substance use, for example, alcohol, opioid or cocaine use disorder, and current or former smoking both increase the risk.
Is there, it is something that the inquiry is going to look at in due course. But is there a particular reason why black ethnic or minority groups are at higher risk? Do you know?
Their genetic makeup is the same as ours,
Yes.
but it may be that their home circumstances are different. They tend to be multi-generational, more so than we are. We tend to live in nuclear families compared to many ethnic minority groups. So there could be societal reasons as opposed to physiological explanations for it. And it's an area that does really warrant further research.
Yes. Because I think it's an area that has been commented on
Yes, indeed. Yes.
very considerably,
Yes.
and data tends to suggest that
Yes.
there's substance to that.
Yes. Yep. Some of the ethnic groups do have a higher prevalence of obesity, and that in itself is a risk factor. So that could be another variable that explains this.
You go on to say the risk of severe COVID, and
Yes.
again you've got a qualification word there, severe, and I take it that you've indicated
Yes,
earlier what
yes.
severe is. It's somewhat subjective,
It is somewhat subjective. Yes. Yeah.
but it's the sort of level of infection that would tend to suggest that it's time to see your doctor.
I guess so. Yes. Yes. Yep.
Yeah. And you say that there are further increasing risk factors, and you list them there. I think they're probably fairly obvious: obesity, diabetes, hypertension, cardiac disease, frailty, and impaired immunity. And you go on to say reduced ability to cough and clear bronchial secretions. We have come across and will continue to come across the concept of impaired immunity or immunosuppressed. Can you just explain what that is?
Yes, the immune system is the body's way of combating pathogens, combating infections. It's very complicated, but there are two sides of the immune system. There's the innate immune system that we're all born with, and that's kind of a general kind of surveillance system that surveys all the potential pathogens that might have got into the body. It's also called the cellular immune system, confusingly, because there are individual cells within that aspect of the immune system that have particular functions and that will go out and seek and destroy pathogens. And the other part, and we're born with that, and that tends to decline with age. The other side of the immune system is the what's called the humoral immune system, which is based on antibodies, and that tends to be disease specific. I don't know if that's disease specific. So we develop antibodies for specific diseases when alerted by the innate immune system, and that tends to get better as you get older. You encounter more diseases, and so your stock of antibodies builds up. And furthermore, sometimes antibodies may be cross-reactive. They may be effective against one particular virus, and they may also be partly effective against a different virus.
May I interrupt at this stage? You indicated, Doctor, that, I think in fact Mr. Gale indicated on your behalf, that the list you give is pretty obvious.
Yes.
And also it's fairly objective, but there's one word you use which I think is a little subjective: frailty.
Yes. Yes.
Frailty, I think many of us, we would all have different interpretations.
Yes.
Perhaps we automatically think of an old person.
Yes.
But what do you mean by frailty there? Are you able to be a little bit more objective?
Yes, it is subjective, and there are frailty indices that will be used in care homes. And my wife was a nurse, was for a long time staff nurse in charge of nursing homes. Actually, there's an important distinction between nursing homes and residential homes there. And so when new residents come into the nursing home or the residential home, they'll be assessed for frailty. And there are different measures, but they combine various factors, like mainly based on mobility.
Yeah. Okay.
And beyond that, I'm
No.
a bit out of my depth, actually.
That helps.
But clearly, people have found that there are people who are old but very robust, and there are people who are old but very frail, and there's the ones who are old but frail who are particularly at risk of COVID-19. And presumably this is because their innate immune system has gradually diminished with the passage of time, whereas their adaptive or humoral immune system is still all right. They've still got antibodies to the range of diseases they've encountered during their lives.
Right, thank you. Sorry, Mr. Gill.
We were talking yesterday about the swine flu epidemic, and that was striking because older people seem not to acquire swine flu, if you remember,
you
because
said
they'd
that,
encountered the same influenza virus in the 50s, but the younger people were getting it because they hadn't.
And I think just to complete the list, you say that people with chronic liver disease, especially cirrhosis, are at a high risk of severe COVID.
Yes.
And I think as was apparent from your papers that you referred
Yes,
to,
it's
this is an area
indeed.
with which you have a particular interest.
Yes, yes.
Could you just read the final paragraph and perhaps expand on it a little? Page 28. There's final paragraph of 215, please.
In the early stages of the pandemic, the crude case fatality rate, meaning the all-age average case fatality rate from COVID-19, was reported in the medical press and medical literature and the press as ranging from 1% to 13 or 14%. This very wide variation in a key measure of pathogenicity was explained at the time as being possibly due to different case definitions used and to some extent the intensive care capacity of hospitals.
Can you explain, because obviously an explanation is being given as to that wide range, and at the moment I have to say I'm slightly struggling to understand that.
Yes, yes. So when the pandemic came along, everyone was taken by surprise, and some centres were reporting 13 or 14% of our patients who we've admitted are dying of COVID-19. Others were saying, well, we're only finding 1% are dying. And it's puzzling that a measure that isn't objective, which is terminal, like such as death, should have accrued such a very wide range of reported observations, and there are a number of explanations. And one is that there are different definitions of COVID cases in different countries. So different case definitions were used, and some of the people dying may not have died of COVID, they may have died with COVID, so that could explain some of the variation. And some countries may have had better intensive care capacity than others.
And even within countries, the intensive care capacity can vary.
Indeed, and some thinking nowadays is that possibly some of the early treatment protocols were actually harmful. They were well-intentioned, of course, but they might have actually been causing more harm than good, because current treatment protocols are very conservative. The current approach in general to COVID is one of medical supportive measures, which Mr. Gale suggested is equivalent to palliative treatment, which is right. That seems to be the best way of managing patients with COVID, with medical supportive measures, and very importantly, nursing them so they're lying on their front, so that the secretions drain out of their mouth, not when they're lying on their back. So
yes. Now you deal with a section on, again, a subject that we will be looking at in some further detail, and that's COVID-19 and pregnancy, and in the general context of women's issues.
Yes.
You've indicated that there was something of a difference. The risk was higher in the earlier stages of the pandemic, and that there was a different level in the Omicron era of the pandemic. Now, I think you indicate in the first paragraph that the risk was higher if, and you give a number of factors, which I think are factors that are associated with risk in pregnancy, and with the complication of the pandemic.
Yes.
And then the data that is available for the Omicron era indicates that pregnant women were subsequently less likely to have a preterm birth or maternal critical care
Yes.
fewer stillbirths and no maternal deaths
Yes.
were delivered in the UK in that
Yeah.
period. So any reason you can
Yes.
postulate for that?
Yes. The Omicron era began in November 2021, as
Yes.
I mentioned earlier. So it began late on in the pandemic. So the explanation may be that the treatment protocols had been adapted by then and were more on the lines of supportive care, which was giving better outcomes, and there perhaps were less interventionist, using aggressive therapies such as intravenous fluid replacement, whereas oral fluids might have been preferred. So this no doubt is being discussed even as we speak, and the answer to that question should become apparent with the passage of time. But that's I can just surmise as to what the reasons might have been.
And also the vaccine program. if you're
Yes,
right.
indeed, yeah. So many of those women would have been vaccinated, and as we will discuss later, the vaccine does seem to does confer, based on the Cochrane analysis, less severe disease.
Right. We move on now to 17.2, who is at low risk
Yes.
for severe COVID infection. Within this passage, there is a perhaps somewhat concerning sentence, and one that perhaps needs to be considered in a little more detail. I'll read it out. In general, COVID-19 has a milder disease course for children and young adults than it does in older adults. The majority of children recover completely after acute SARS-CoV-2 infection, and any persistent symptoms will improve with time. Now, that, I think you're presenting that
Yes.
from the point of view of a public health physician.
Yes.
And obviously, you are looking at, if I can put it this way, the larger, bigger picture. And of course, within that larger, bigger picture, there will be and will have been exceptions to the generality that you are stating there.
Yes. Yeah.
And
Yes.
I think yesterday, we talked about it, that it's perhaps of little comfort to those who have lost someone, whether that person be in the area that is perhaps at most risk, such as the elderly, but also those who have lost someone in the apparently less risk category.
Yes.
You then go on to talk about the case fatality rate. This is in the third full paragraph on that page, and then you have set out a table. Can you tell me where that table comes from, and perhaps just take us through it, please?
Yes, that table is taken from the what's called the Green Book, which is the Department of Health manual that is used by anybody who's in any way involved with the vaccination process, whether epidemiologists or GPs or nurses who administer vaccines. And it used to be a Green Book, but nowadays it's all online. So this table was taken from the online version, published earlier this year. I've got a copy there. And the table shows deaths in 2020 in England, but I think the table can be generalised to Scotland as well. And it breaks the deaths that one can attribute to COVID down into males and females, and it stratifies them very helpfully by age groups.
Yes.
So the first line is the deaths, the deaths that occurred in the under 18s. So looking really at the right-hand column, there were 32 deaths in England in 2020 in the under 18s from that are attributed to COVID-19. And so there's a very, very small rate of death in the under 18s in that year. And the following year might have been even smaller because, as I was saying, the treatment protocols were better. But 2020, the height of the pandemic, the rate was per 100,000 children, 0.26. So that's equivalent to 2 per million. 2 out of a million children would have died of COVID in that year. And as we move up the age categories, that number gets higher and higher until we get into those who are 85 and over. And you can see there were 26,954 deaths in total that attributed to COVID, so a massive number in the 85s and over. And the rate there is for every 100,000 people who are 85 and over, it's actually it's 19,160.
1,900, I think.
Well, that's sorry, for every million. I think.
Every million.
Yeah, so let's stick with 100,000. Thank you, my lord. Yeah. So it's every 100,000, it's 1916.
Yeah.
I did a little calculation on that, and if you take the over 65s, that counts to 59,628 deaths. Those over 65. So, and that's like 89% of all the deaths. 89% of all the deaths were in those over 65, and in fact, 1 in 4 of them, and 1 in 5 of those, 1 in 4 of them, was in those over 85.
Yeah.
So it was very much a disease related to age and extremes of age, based on the England figures. But I would confidently suggest that Scottish figures would be comparable.
Yes. I don't see any reason why they would be different.
I don't see any reason why.
If you go over the page to page 30, you make a reference there to a very small majority of children infected with SARS-CoV-2, approximately 1 in 3,000,
Yes.
developed multi-system inflammatory syndrome with Kawasaki disease-like features. This is known as mucotinosis lymph node syndrome, and as pediatric multi-system inflammatory syndrome temporally associated with SARS-2 COVID. You say a small minority of children. What would be the symptoms of that and the effect of that?
Well, again, it would depend on whatever system is being involved. So, because COVID can infect any system, it's a multi-system disease, as we agreed yesterday. I guess any system from the heart, the kidneys, the brain, the lungs, or maybe many systems at the same time.
Anything that was the subject of the attack.
Yes, indeed. Yeah. I had meant to put in there a further point, but perhaps it was obvious. But one of the standard textbooks I've been citing did go on to say that usually they get better. Usually they get better. That's we have to take that on trust.
Yes. I'm reminded to can you just perhaps indicate what, probably know the word Kawasaki from different contexts, but could you tell us what Kawasaki disease is?
I don't know what that is. No.
You don't know?
No. It's clearly a very rare disease that paediatricians are familiar with, and they were surprised to see this in children.
Okay. Right. You then go on to the pathological processes that occur in COVID-19. And I think that probably we can simply read that section of 2.18 for ourselves and perhaps move on to 19, which are the clinical features of COVID-19. And you refer, first of all, to early features. Perhaps you could just go through those, please.
Yes. In patients with symptomatic COVID-19 infection, the initial symptoms are non-specific and appear after an incubation period of approximately 2 to 7 days. And typically these initial symptoms include fever, headache, myalgia meaning muscle pain, and malaise meaning general unwellness. At the same time, or around the same time, the patient may also experience anosmia, which is loss of smell, and dysgeunia, which is distortion of taste.
Yes. And I think we probably are all familiar with those being publicised at the time of the pandemic. And I think any of us who've had COVID will probably recognise all of those symptoms.
Yes.
You then go on to the later features. Again, it'd be useful if perhaps if you just read through that section, please.
Yeah, so the majority of individuals with COVID will recover spontaneously, but in China, up to 80% of those who had been infected had only mild symptoms not requiring hospitalization. But in those other patients with severe symptoms, over a matter of days or weeks, COVID-19 may progress to one or more severe syndromes. Syndrome is a symptom cluster, so it could be respiratory syndrome with dry cough, sore throat, nasal congestion, shortness of breath, and low oxygen saturation, or it could be some kind of cardiac syndrome, or coagulopathy, meaning clotting disorder syndrome, or some other immune system that results in treatment difficulties.
Yes. And would you just continue on reading it?
Yes, so other symptoms besides these syndromes, such as profound fatigue and skin rashes, may also be present. And 50% of patients with confirmed COVID-19 will also report gastrointestinal symptoms, mainly diarrhea in 38% of those who are sick, and vomiting in 13%. And sometimes the patient will have gastrointestinal symptoms and nothing else.
Yes.
And then some patients with severe COVID-19 deteriorate rapidly and develop life-threatening complications, including thromboembolic events, that means clotting events, cardiac disease, acute kidney injury, sepsis, septic shock, and multi-organ failure, which is the herald of death.
Yes. And just continue on, please.
So natural immunity, when you've acquired SARS-CoV-2 naturally, natural immunity lasts up to 1 year before beginning to wane, and that sort of fits in with the natural immunity we normally experience with influenza. Although new strains and variants, such as Omicron, appear to exhibit greater immune escape, so they manage to evade the immune system and they make reinfection more common.
You now deal, Doctor, with how does COVID-19 present in the elderly, and I think
Yes.
we look at this bearing in mind the material that we've looked at
Yes.
in relation to death rates.
Yes.
And so perhaps you could, again, it's perhaps a section that is useful for you to read through, albeit that I
Yes.
appreciate you have a table there, and if you could just
Yes.
read the text and just take us through the table.
Yes, so in the elderly, the presentation is different and atypical. The elderly may experience delirium and reduced mobility, and also immunocompromised individuals as well, and often they don't have a fever. And so there's a table summarising how COVID-19 presents in the elderly. And so there are non-specific signs and symptoms are different. So often they don't have a fever, they may not be breathless. They may, however, become delirious and even severely delirious. And they often don't have lung problems particularly, but they can have clotting problems, thromboses, or gastrointestinal upset, diarrhea and vomiting, like we've just talked about. So it can be difficult to pick up COVID-19 in the elderly if you're caring for them, or a doctor or nurse. And the outcomes are different. Often they carry COVID-19 virus asymptomatically for extended periods. The elderly have high morbidity. That means they have more likely to have severe disease and mortality. They're more likely to have a fatal outcome. And the elderly who survive COVID-19 will often experience functional decline, meaning their natural ability to function in their environment will get worse, and they may need rehabilitation, which is likely to be extensive and expensive. Here's the word frailty again. Those old people who are frail, over and above being old, have particularly poor outcomes. But even people who are very, very frail, it seems, can acquire COVID-19 and survive. And then so frailty assessment is a good tool. I'm not quite sure how it's done, but clearly there are numerical measures you can use to categorise somebody as being frail or not, and they can help people, for example, who manage care homes to decide as to how to manage a particular individual and what risk they may or may not be at. Mm. But they shouldn't be the only consideration. Other factors should be involved as well.
Now, obviously, all of those signs and symptoms in an elderly person would be distressing.
Yes. Oh, yes.
For that person, yes. And for those who are their relatives, carers, loved ones.
Yes.
But particularly, I suppose, delirium would be...
delirium when the person in front of you is just not the person that you knew 2 weeks ago. They're someone quite different,
You go on now to a subject that I think we are hearing more and more about, and that is long COVID.
Yes.
And the audience will be aware that the inquiry has published an opinion on long COVID to the extent that it intends to investigate long COVID. So with that in mind, could you just take us through that relatively short passage that you have at 222 at page 33 to 34 on long COVID?
Yes, it's relatively short because there isn't much about it in the textbooks as yet. It's a recent phenomenon, but here we are. As is the case also with other viral infections, such as infectious mononucleosis, that means glandular fever. Glandular fever can often result in very long-term debilitating symptoms. COVID-19 may also give rise to prolonged symptoms that persist for more than 4 weeks. And this is known as long COVID. And in the UK, 4 to 4.5% of COVID-19 cases report long-term symptoms 12 to 16 weeks after initial infection. So about 1 in 20 of cases. Other terms for long COVID include post-COVID syndrome and post-acute sequelae of COVID-19, PASC. And the reported symptoms of long COVID are variable, and they involve most organ symptoms and affect both physical and mental health. And commonly reported long COVID symptoms are shortness of breath, fatigue, headache, and difficulty in thinking or concentrating. And in addition to those 4 common symptoms, there is evidence of long-term cardiovascular sequelae of COVID-19, and including cerebrovascular disorders, and I guess that means sort of minor strokes, transient ischemic attacks, cardiac dysrhythmias where the heart rhythm isn't normal, heart failure where the heart pump is no longer efficient, ischemic and non-ischemic heart disease, same thing really, myocarditis, which is inflammation of the myocardium, the muscle of the heart, pericarditis is inflammation of the fibrous sac surrounding the heart, and thromboembolic disease, which means long-term clotting disease. So all of those would fit under the category of long COVID.
Yes. In this inquiry, we have a group representing, it's called long COVID kids.
Yes.
And so obviously children suffering long COVID. Is that something of which you are aware of any research having been done?
I would hope there's extensive research being done into long COVID, but I'm not familiar with the details of what research is being done in various centres. I believe it was first recognised as an entity in the UK, and initially other countries weren't aware of this phenomenon, but they now have become more aware, so maybe research is being done in other countries as well.
Yes, thank you.
The belief.
I'm sorry.
I'm so sorry. I understand that the belief is that for most people with long COVID, they do gradually get better. For most, obviously not for all, and by analogy with glandular fever type symptoms, where people can be very exhausted for months and months, but gradually they get better. But it's in the short term they will be often very disabled indeed.
Right. You move on to a section on diagnostic tests.
Yes.
And I'm, with respect, going to take that as read. I think a lot of the tests that are, they are quite well known to us from our own experiences, as are the, and I'm not going to take you through the laboratory findings or the radiological abnormalities. But what I'd like to take you on to is 226 at page 36, please, which is how is COVID-19 treated and medical supportive care. Now, I think this is something, again, we touched on yesterday under reference to I think, one of the Cochrane reviews. And perhaps you could just read through what you've said there in section 226.
Yes. In the early stages of the pandemic, COVID-19 patients with severe respiratory distress were often treated aggressively with intravenous fluids and mechanical ventilation. It became apparent, however, that intravenous fluids could exacerbate fluid in the lungs and further reduce oxygenation. And another early clinical observation was that lying in a prone position, which is on the stomach, is better than lying in the supine position on the back, which is how you lie in intensive care, you're on your back. But if you're lying on your stomach, this was found to lead to improved oxygenation in patients who were receiving supplemental oxygen therapy through a face mask or nasal tubes. And this simple nursing measure resulted in fewer intubations. Intubations is where the patient is, first of all, paralyzed through drugs, and then a breathing tube inserted into them. And the intubations themselves were an additional cause of morbidity and mortality. All of that is taken from standard textbooks, not my opinion. And then the current mainstay of COVID management is medical supportive care. COVID-19 patients who are coughing should initially be managed using simple non-drug measures, e.g. honey. This is the British National Formulary Advice to doctors. Give them non-drug measures initially. And if the patient has a distressing cough, you could use a cough suppressant, a simple cough linctus in the short term, for example, codeine phosphate. If the COVID-19 patient has a fever, the pharmaceutical advice is tell them to drink fluids regularly to avoid dehydration and to take simple antipyretics, drugs to bring down the fever, for example, paracetamol or ibuprofen or brufen.
The second aspect of COVID-19 treatment is pharmacological therapy.
Yes.
And you say that most drugs tested have shown marginal or disappointing efficacy against SARS. And you give the reference at footnote 186, which I think is to Loughton.
Yes.
Essential Human Virology.
Yes.
And it's either a paper or a book from 2023. So it's post the height of the pandemic.
Yes.
Is it to I suppose most of us who immediately think that there's a pharmacological remedy for anything that we're suffering.
Yes.
That may sound quite a surprising finding.
Yes.
Did you find it surprising?
Well, first of all, I might qualify that by saying that the steroids don't come to that category. Steroids seem to be effective, dexamethasone. But I think what she's talking about there are antiviral drugs, so viral-specific drugs. Steroids come to the category of sort of standard, not non-complicated measures. So, but a large number of antiviral drugs at various times were put forward as the wonderful remedy, and I think one came into the timeline actually with the word saying, "Great news! This drug has now been antiviral drug has now been approved for COVID," and it was a little bit surprising to see to see it stated that antiviral drugs don't seem to have much efficacy, and then I got a bit worried about this, because in the UK inquiry they were told the opposite. They were told that drug therapy had a remarkable effect in improving COVID outcomes. But again, I think what was really meant there was probably dexamethasone. Because I was a bit concerned last week, I thought, well, I'll see if there's a Cochrane review about, I just chose one drug at random, remdesivir, to see what the Cochrane people say about it. I found a Cochrane review which was published earlier this year, and so it's on publicly available. I'll just read one line from a Cochrane review, published in January 2023, and it's called Remdesivir for the Treatment of COVID-19. They found a number of studies. So they used the standard Cochrane methodology, and they found 9 randomized controlled trials of remdesivir to treat COVID-19, 11,218 participants, and they were randomized to receive remdesivir or not receive remdesivir. And I won't go through the details of the studies, but they're available. But the author's conclusions are based on the available evidence up to the 31st of May 2022, which is their cut-off point for trial. Remdesivir probably has little or no effect on all-cause mortality or in-hospital mortality of individuals with moderate to severe COVID-19. So that was certainly the position as of last year. So
you see, you've found that. Was that produced in the bundle of documents?
It wasn't. So we could have had Cochrane reviews for every test.
I'm sure, but could we get a copy of that, Mr.
Sure.
Please?
Yes.
Thank you.
And indeed there will be a number of other antiviral drugs are mentioned there, my lord, and there will certainly be Cochrane reviews either published or in progress for all of those. And of course, bearing in mind that Cochrane reviews are dynamic, and as they admit, in a year's time they might change their view, but it's unlikely they would change it. But
there is only one other excuse me. Yes, there is only one other sentence I'd like to take you to. It's page 39.
Yes.
And it's in relation to it's after the various drugs that are mentioned, including remdesivir.
Yes.
There's a paragraph which says the safety of COVID-19 antiviral treatment during pregnancy has not been established. And I think the reference you give to that is from the British National Formulary.
Yes. It's to yes. Thank you. Yes. Yes, the British National Formulary are pretty conservative. I've become rather conservative, and they don't want doctors to start giving antiviral treatments, perhaps because the patient is demanding it, because they feel that the safety margin is still under exploration.
Yes. Lord, that's perhaps a useful point at which to break.
Of course. Yes, thank you. We'll take 15 or so minutes now. Thank you very much indeed. Thank you, Doctor.